All right, Ninja Nerds, in this video, we are going to talk about medullary lesions. We'll talk about medial medullary syndrome, lateral medullary syndrome. Before that, though, I want to take a teensy bit of time to just kind of quickly, very quickly, we're going to brush through this quick anatomy of the medulla, and we're going to talk a little bit about the blood flow. The reason why is it's very pertinent for us to understand a little bit about the anatomy and some about the blood flow in order for us to understand these syndromes. So let's go ahead and do that first. All right, Ninja Nerds, so what we got to do first, okay, before we start going over all these syndromes, is we have to talk a little bit about the anatomy and a little bit about the blood flow. So what I want us to understand is, again, if you want more detail on all this stuff, go watch our video where we have all the in-depth discussion about the anatomy and the function of the medulla. But really quickly, what I want us to understand is I'm going to draw a small little diagram here. Okay, this is our sagittal section, right? If you guys remember, midbrain, pons, medulla, spinal cord, cerebrum, cerebellum, right? We're taking a section, this cross section, at more of the top aspect. And actually, thankfully, most of the syndromes, medial medullary and lateral medullary syndrome, most of them occur at this top part. So let's say that we took a section here at 1. That's the most rostral, the most superior, the most at the top portion of the medulla, if you will. And then here at the bottom, as we go towards the medulla into the spinal cord, that's going to be the most caudal portion. The reason why I want to mention the difference between these two is that the blood flow is just a teensy bit different to the medulla at the most rostral portion and the caudal portion. And I'll discuss that. But for right now, I just want to quickly brush over the anatomy at this section 1, okay? Which is going to be pretty much at that pons medulla junction. Then what we'll do is we'll briefly go over blood flow, and I'll talk about the difference in blood flow at these two portions, okay? All right, so let's go ahead and take a look at this section here. Quickly, we're going to say again, ventral medulla, dorsal medulla, okay? We're going to kind of quickly go through these structures because it's pertinent we understand them. First thing here in the dorsal aspect, what do we have here? I'm going to abbreviate them. This is our hypoglossal nucleus, cranial nerve 12. Here in blue, we have the dorsal nucleus of vagus. Next to it, as we go laterally, we have the nucleus of tractus solitarius. As we go more laterally, we have the medial vestibular nucleus, and we have the inferior vestibular nucleus. As we go a little bit more laterally, you got these purple guys here. What are these guys? That's your dorsal cochlear nuclei. This one is your ventral cochlear nuclei. Go a little bit more laterally. What is this son of a gun? He is the inferior cerebellar peduncles, right? Okay, move continuously here. What do we got here? This is our ventral or anterior spinocerebellar tract. So we'll put ventral spinocerebellar tract. Okay, move a little bit here. Now we got this bad boy. What's this son of a gun right here? This is our inferior olivary nucleus. So inferior olivary nucleus. Okay, move a little bit here. What do we got here? This is our corticospinal tracts, which is going to be carrying those descending motor fibers. What do we got here? This is our medial lemniscus. This blue guy here. This is our spinal lemniscus. Come over here to this green structure. This is our spinal nucleus of the trigeminal nerve, and this is the spinal tract of the trigeminal nerve. As we move here to this green structure, this is the inferior salivatory nucleus. This blue guy here is our nucleus ambiguus. This orange guy here is our descending sympathetic tract. So this is the descending, here we'll put DST, descending sympathetic tract. Move back medially here. The black one here, this is the tectospinal tract, and this purple one is the medial longitudinal fasciculus. One more time so that we completely understand this. Hypoglossal nucleus, dorsal nucleus of vagus, nucleus of tractus solitarius, medial and inferior vestibular nucleus, the dorsal ventral cochlear nucleus, inferior cerebellar peduncles, ventral spinocerebellar tract, inferior olivary nuclear complex, corticospinal tract, medial lemniscus, spinal lemniscus, inferior salivatory nucleus, spinal tract and spinal nucleus, the descending sympathetic tract, the nucleus ambiguus, inferior salivatory nucleus, tectospinal tract, and medial longitudinal fasciculus. We understand this. Now it's going to be easier for us when we cover the lesions. Okay, next thing we got to talk about is a little bit about this blood flow. Okay, because the blood flow to these different sections of the medulla is critical. You guys remember, from the circle of Willis, what do we have? These arteries coming up here. What are they? Your vertebral arteries. They're coming up through those transverse foramina within the cervical vertebrae, right? Eventually, as they come up here, what do? They eventually start coming together, getting ready to fuse. Whenever they kind of fuse together, what do they make? They make your basilar artery. As they move up towards the midbrain, they give off the posterior cerebral artery. So posterior cerebral artery, vertebral artery, this would be your left. This would be your right. Here, we'll put that right vertebral artery, left vertebral artery, posterior cerebral artery. Now, along the way, here's our basilar artery. We also are going to give off some branches. Off of the vertebral arteries, you're going to have some branches. You see off this vertebral artery, we're going to have a branch coming down here and one coming like this. This artery that kind of comes off of the vertebral arteries and works its way down the anterior aspect of the spinal cord is called the anterior spinal artery. There is another one, and it works in the back. Okay, so it works in the back of the medulla and down the back of the spinal cord. And that one is called the posterior spinal artery. So again, the one in the anterior portion formed at more of the superior aspect or rostral aspect of the medulla is the anterior spinal artery. The one that's formed just a little bit more inferiorly and on the posterior aspect of the medulla and down the spinal cord is the posterior spinal artery. You also have this branch coming off here. What is this guy? This is your PICA, right? The PICA is your posterior inferior cerebellar artery. Posterior inferior cerebellar artery. What else do you have? You also have this one. This is your ICA. ICA is going to be the anterior inferior cerebellar artery. Anterior inferior cerebellar artery. And then the last one you have coming off of this portion around the midbrain is your superior cerebellar artery. Okay? So what are the arteries that we want to focus on here? The ones that we want to focus on, I'm going to kind of highlight here, is your vertebral arteries. They are going to be supplying the medulla, as you can see here. The other one is going to be this anterior spinal artery. This is supplying the medulla also. And even as you see out here, the PICA, the posterior inferior cerebellar arteries. And the last one that I want to mention that you can see at the most caudal portion of the medulla, teensy bit of it, is the posterior spinal artery. So we know that these are the main ones. The most medial portion is supplied by the particularly the anterior spinal arteries. A little bit more laterally is the vertebral arteries, and then the most laterally and kind of posterior are your PICAs. So let's kind of shade that in here. So again, if you kind of imagine here, I'm going to kind of make this kind of like line here, this kind of red line here. All of this portion here that I'm kind of highlighting, all of this is all supplied by what vessel? The anterior spinal artery. So this whole portion here, all of it is supplied by the anterior spinal artery. As we go a little bit more laterally, what is going to be supplying this portion? Let's do it in a different color. We'll do it here in this kind of like greenish color here. This guy right here is going to be the vertebral arteries. So your vertebral arteries are supplying this portion. So you have your vertebral arteries supplying this portion. And then the most lateral portion of the medulla, kind of this portion here, is supplied by the posterior inferior cerebellar artery, your PICA. Okay, so again, what I want you to remember is just in the simplicity's sake, more medial, midline is anterior spinal artery. Kind of a little bit here in the middle is your vertebral arteries, and the most laterally is your PICA. The big ones, the two ones that you can't forget, you have to remember this, is your PICA and your anterior spinal. The reason why is, what is the anterior spinal artery supplying? More of the medial aspect of the medulla. Guess what that's going to cause? If there's a kind of an occlusion in that vessel, it's going to cause medial medullary syndrome. If there's an occlusion in PICA, which supplies more of the lateral aspect of the medulla, what's that going to cause? Lateral medullary syndrome. So it's pretty simple. Now, the last teensy bit of the thing that I want you guys to remember is, if I were to just kind of draw a very quick diagram here, I just want you guys to remember, here's our midline, right? If we're at the most caudal portion, so this is going to be at the caudal portion. Here we covered at the rostral portion. At the most caudal portion, it's going to be pretty much the same blood flow. I'm going to put here anterior spinal artery. Then you're going to have here the vertebral artery. Then you're going to have here your PICA. The only thing that's different is that a teensy bit of the posterior aspect of the medulla and the most caudal portion is supplied by that posterior spinal artery. Just one thing I wanted to make sure that we're clear about, okay? But for the most part, big ones, anterior spinal and PICA. Now that we know our anatomy and our blood flow, let's move on to the lesions. All right, so now that we've kind of covered the neuroanatomy, we talked about the blood flow. Again, big one I want you to remember, anterior spinal, more the outer aspect, is going to be the PICA, okay? So this one that we're covering is going to be a lesion involving primarily what vessel? Because it's going to be a medial type of lesion in the medulla. This is medial medullary syndrome. Let's write that down. What is this son of a gun here? This guy is our medial medullary syndrome. Okay, so what vessel is causing the infarct here? This is going to be an infarct of the, it's going to be an infarct or occlusion of the anterior spinal artery, whether it be an embolus, whether it be a thrombus, whatever. The anterior spinal artery is occluded. What three structures is damaged? That's what I want you to remember, okay? Three structures that are damaged. You guys remember the neuroanatomy here. What was that pink structure there? The hypoglossal nucleus. So the hypoglossal nucleus and the nerve coming out. All right, so the hypoglossal nucleus, and if you guys remember, the nerve is obviously going to be exiting here. It's going to be leaving like this, right? That's also going to be damaged. So the hypoglossal nucleus and the hypoglossal kind of nerve is going to be damaged. What else is damaged? What is this blue structure here called? That's your medial lemniscus. And your medial lemniscus is obviously important because it plays a role within that. Sensations, and we'll talk about what sensations. And in the ventral aspect here, this is going to be the corticospinal tracts. So three structures that are damaged: hypoglossal nucleus and nerve, medial lemniscus, corticospinal tracts. If those are damaged because of a occlusion of the anterior spinal artery, what are the clinical manifestations that these patients will present with? Okay, let's look here at this first diagram. All right, so we'll talk about the hypoglossal nucleus first. So the hypoglossal nerve. Hypoglossal nerve. If this bad boy is affected, how will the patient present? Well, you guys got to remember, what does the hypoglossal nerve do? We talked about it in that medulla video. We said that it supplies the tongue muscles, right? The styloglossus, the hyloglossus, the genioglossus, which I said is a really important one that I want you to remember, particularly pertinent to this. It also supplies like the chondroglossus and your intrinsic muscles of the tongue. But the big one that I want you to remember here that we're going to kind of discuss here is that genioglossus muscle. So let's write this guy down here. So this is our genioglossus. Do you guys remember what this muscle does? The genioglossus of the tongue, we said, primarily helps with protrusion of the tongue, right? So for example, this is the right genioglossus. This is the left genioglossus. The right genioglossus will protrude the tongue forward and a little bit towards the left. The left genioglossus will protrude the tongue forward and a little bit to the right. So let's follow this issue here. Hypoglossal nerve, it supplies the ipsilateral genioglossus here. So here's going to supply the right nucleus, and right hypoglossal nerve supplies the right genioglossus. The left hypoglossal nucleus and nerve supplies the left genioglossus. For the sake of our diagram, the lesion is involving the left hypoglossal nucleus and the nerve. So if that's the case, then hypoglossal nerve stimulates the genioglossus to contract, and it'll cause it to protrude and move towards the left. But because this left genioglossus is inhibited, it doesn't have enough stimulation, the direction of it protruding towards the right side is going to be inhibited. It's not going to be able to move towards the right. So because of that, this movement here, let's actually draw it like this. This movement here of moving the left genioglossus, kind of causing the tongue to protrude towards the left, what's going to happen here? As we try to do this, it'll move to the right. It'll be able to move to the right, but this guy will not be able to move to the left, right? So it's going to be inhibited. Now, the right genioglossus is going to be unopposed. So whenever the right contracts, it protrudes it to the left. Whenever the left contracts, it protrudes it a little bit to the right. But now that right genioglossus is going to be unopposed and overpowered. And it's going to start causing the genioglossus on the right to cause the tongue to protrude more towards the left. So what does that present like? So for example, if I were to kind of show you, I'm going to have my tongue, right? If I had a lesion involving the left hypoglossal nerve, when I try to protrude my tongue, that left side is going to be weak, right? It's not going to be able to protrude it to the right. Which way is the tongue going to go? It's going to deviate to the side of the lesion. What's that side? The ipsilateral side. So it's ipsilateral tongue deviation. Let's write that down. So beautiful when things make sense, right? So ipsilateral tongue deviation. Okay, so that would be indicative of more of a lower motor neuron, in this aspect, more of the hypoglossal nerve lesion. If it was upper motor neuron, it'd be a little bit different, okay? So that covers that. Let's move on to the next one. And the next thing that is damaged here is that medial lemniscus. So if the medial lemniscus is damaged, what will happen here? So let's talk briefly about the medial lemniscus. Okay, obviously we know that the medial lemniscus is important for carrying sensations. What kind of sensations? I'm glad you asked. So you have here muscles, right? These muscles are going to have some spindles, right? Some muscle spindles that are going to be connected to your muscle, like you're connected to your muscles, your joint tendons, your joints, your tendons, your joint capsules, ligaments, all those sons of guns. And it's going to be sending information about the position of your muscles, your tendons, your joints in space. And what it does is it sends this information into your dorsal root ganglion, comes into that posterior gray horn, doesn't synapse on a first order neuron here, it doesn't synapse on a neuron here, comes into that dorsal white column, and then ascends upwards into the medulla, right? Same thing, it also is picking up sensations from the skin. What kind of sensations? It'll be picking up fine and discriminative touch, vibratory sensations as well, and sending that information via this pathway. Now, what happens is that eventually this will ascend upwards, right? It'll synapse on what structure here? It'll synapse on the different nuclei. For example, this is the fasciculus gracilis. Let's say here we have the fasciculus cuneatus. It'll synapse on the nucleus cuneatus and the nucleus gracilis. Then what will happen is the nucleus gracilis and the nucleus cuneatus will give off their axons that'll then cross over to the contralateral side and ascend upwards, right? And ascend upwards as the medial lemniscus. We have the medial lemniscus here. So let's follow the lesion. It's on the left side, right here. We got to follow it back. Contralateral. So there's contralateral. So here's the lesion on the left side. The sensations that we lose is on the right side. That's the contralateral side. So what are we losing? Well, we're losing contralateral loss of position sense, right? So it's contralateral loss of proprioception and fine and discriminative touch. It's contralateral loss of what sensations? Proprioception, vibrations, and touch. Vibrations, here we'll put a comment. Vibrations and touch. Sweet. That covers that. Okay, so we covered what happens with the hypoglossal. So far it's ipsilateral, tongue deviation. Contralateral, loss of proprioception, touch, and vibrations. What's the last structure damaged here? The last structure that's damaged here is the corticospinal tracts. So the corticospinal tracts. As you guys know, this is our descending motor tracts. They're sending information. As you would know, there's going to be up here's the, pretend this is the cortex. So that's our upper motor neuron. It's sending down the descending information, right? Coming down through that internal capsule, moving through the crus cerebri, moving through the pons. As it moves through the pons, it kind of moves into the medulla, right? And as it comes to the medulla, at the bottom of the medulla in this pyramids, this is the pyramids, right? As it gets to the bottom, what does it do? It crosses and kind of crosses here, right? So This will then do what? It'll descend downwards into the lateral white column. Lateral white column, 85% of the fibers will. And eventually it'll synapse on these lower motor neurons, because this is our upper motor neuron. This is our upper motor neuron. These were our lower motor neurons. All right? Comes down, descending cortical fibers, moves through the midbrain, through the pons, through the medulla, crosses at kind of the lower part of the pyramids, moves into the lateral white column, and synapses on these lower motor neurons. These lower motor neurons then go via alpha and gamma motor neurons to your skeletal muscles and cause these muscles to contract. Now, where's the lesion? The lesion is right here on the left side, involving that corticospinal at the most rostral portion, we said. It crosses caudally, though. So let's follow this lesion. Oh, contralateral side. The lesion was on the left. The weakness, because this muscles aren't going to contract, the weakness is going to be on what side? On the right side, the contralateral side. So what is this? Contralateral hemiplegia. Okay, so contralateral hemiplegia or hemiparesis. So hemiplegia is paralysis, and paresis is more of the weakness. Okay, so contralateral, we'll just put weakness. Contralateral weakness. Okay, sweet. So someone says, medial medullary syndrome. What part of the medulla is affected? Medial. What vessel is occluded? Anterior spinal artery. What are the three structures damaged? Hypoglossal nucleus and the nerve. Medial lemniscus, corticospinal tracts. What are the three presentations? Ipsilateral tongue deviation, contralateral loss of proprioception, fine touch and vibration, and contralateral hemiparesis or weakness. All right, so let's cover the last lesion here. This is going to be lateral medullary syndrome. Why? You guys remember, this was primarily supplied by what structure? The anterior spinal artery. More of this portion was supplied by the vertebral artery. The most lateral kind of posterior aspect here was supplied by the PICA. And that was the other one that I wanted you to remember. So the PICA is going to be the vessels that is going to be occluded and cause damage to the structures in this portion of the medulla, the lateral portion of the medulla. So this is called lateral medullary syndrome. You guys are so intelligent. So lateral medullary syndrome. Okay, so lateral medullary syndrome is going to involve what type of structures in here? Okay, what did we call these guys? So we had hypoglossal nucleus, dorsal nucleus of vagus, nucleus attractus solitarius. What did we say was next? The medial vestibular nucleus, the inferior vestibular nucleus, the nucleus ambiguus, the descending sympathetic tract, the spinal nucleus, and the spinal tract, the inferior cerebellar peduncles, your dorsal cochlear nuclei, and your ventral cochlear nuclei. All those things. Oh, what else do we got here? Spinal lemniscus. So lots of structures are damaged here in this lateral aspect of the medulla. So again, vestibular nuclei, we're going to cover that one first. So let's see what happens whenever there is damage to these structures. How will the patient present? So there's occlusion of the pica, damages the lateral medulla. It's going to affect the vestibular nuclei. So what happens here? What is kind of the presentation? Well, really quickly, what does the vestibular nuclei do? You guys remember from the millions of times we've talked about it, that these guys are going to be the superior, medial, inferior, and lateral vestibular nuclei, right? And they're receiving information from what structures? The inner ear, right? So they're receiving it from the cristae, and they're receiving it from the macula, right? And that's the inner ear structures. They're picking up dynamic equilibrium, they're picking up static equilibrium, so motion. They're going to send this information to these vestibular nuclei, right? Via the vestibulocochlear nerve. The vestibular nuclei do what from there? They do a bunch of crap. They can send information upwards, right, to what things? They can send information to the sixth nerve nuclei. You guys know that you guys got the sixth nerve nuclei here. And then you got your third nerve. And then you got your fourth nerve nuclei, right? And what happens is when it stimulates this sixth nerve, the sixth nerve will then do what? It'll send fibers upwards and cross, right? And what is this thing's called? That's our medial longitudinal fasciculus, right? That helps to conjugate our eye movements. So that's one thing. We also know that it sends information into the cerebellum to help with letting the cerebellum know of basically our equilibrium sense. It also sends information downwards to our skeletal muscles to help contraction of the anti-gravity muscles or extensor muscles. So it does a lot of stuff. So whenever there's damage to these vestibular nuclei, some of the big things that you want to remember here is that whenever there's damage to a lot of the things that are connected to the inner ear, it's going to produce this sense of loss of equilibrium or kind of a disequilibrium. And that can present as vertigo, okay? And sometimes with vertigo, people kind of have this, the spinning sensation. They can have an associated nausea and vomiting associated with it. So what are the ways that the patients would present? They might have some effect of the eye. So there might be some type of diplopia, maybe from some skew deviation. But the big thing that I want you to remember is that it's really going to be having some disequilibrium, which will present with vertigo. Okay, so it'll present with vertigo. And this is more of a central vertigo. We'll have another video on that someday. And associated nausea and vomiting. We'll write it shorthand, okay? So vertigo, nausea, and vomiting, and maybe some diplopia because you're affecting this kind of medial longitudinal fasciculus. There may be some type of like potential skew deviation. But again, vertigo, nausea, vomiting is what I'm really looking for here, okay? All right, good. Next structure. The next thing that we damaged is we go here, medial vestibular nucleus, inferior vestibular nucleus. What else did we hit? We got those cochlear nuclei. Those sons of guns got busted up too. What do they receive information from? They receive information from the inner ear as well, but they receive it from the spiral organ of Corti. This is the inner ear structure of the cochlea, which is responsible for hearing, not equilibrium, hearing. They send their information to these cochlear nuclei via the vestibulocochlear nerve. The cochlear nuclei do what? You guys know this already. Some of the dorsal acoustic striae will just go straight up. The ventral acoustic striae will actually kind of come up and synapse on what's called the superior olivary nucleus. Same thing over here. Synapse on that superior olivary nucleus. And then ascend upwards, right? But either way, these fibers that are ascending upwards here, that are coming up here, this is all a part of what structure? The lateral lemniscus, right? So this is the lateral lemniscus, lateral lemniscus. This would be the right, this would be the left. The big thing that you guys should remember is what are the cochlear nuclei responsible for? Hearing. And because of that, there's going to be, again, damage to these cochlear nuclei. So if you have damage to these cochlear nuclei, they're sending sensations about hearing. Where is it going to? It's going to these cochlear nuclei. So what happens is the connection to the spiral organ of Corti is damaged here. They're going to have some type of deafness, kind of a sensory neural deafness, but it might be more predominantly on the right side. So what else can they present with? Because you damage these cochlear nuclei, they may present with more of a kind of a unilateral sensory neural deafness. Okay? Okay, so there might be a little bit of deafness, vertigo, nausea, vomiting. Let's move on. Okay, we hit the medial and inferior vestibular nuclei. We hit the cochlear nuclei. We got that orange structure. What is that son of a gun? That bad boy right there is going to be the descending sympathetic tract. You guys remember in the hypothalamus, there's a sympathetic portion and there's a parasympathetic portion. We're going to say that this portion, this blue portion here, is the sympathetic nervous system portion. There's nuclei in here that are going to connect and have these descending fibers that are going to move downwards through the midbrain, through the pons, through the medulla, into the spinal cord, and give off some axons to some of the preganglionic motor neurons that are present here in the portion of the spinal cord from T1 to L2, right? And what happens is these preganglionic motor neurons will eventually move upwards through all the different ganglia within the neck, right? It eventually goes up to what's called your superior cervical ganglion. And the superior cervical ganglion will synapse on these guys. This is your postganglionic motor neurons. And they'll move out and supply parts of the eye. They'll supply, for example, the muscle of the actual pupil, the dilator pupillae. It'll also go over here and supply one of the muscles of the palpebra that helps a little bit with elevating the eyelid. And it also can go and supply some glands on the face, right? So here, we'll make like a little gland here. It also can supply some of the sweat glands in the face. Now, if you damage this tract, let's say that this is on the left side. So let's say that this is that left descending tract. If you damage the left descending tract, the left pupil is not going to be able to dilate. So the left pupil won't be able to dilate. The left upper eyelid won't be able to elevate. And the left side of the face won't be able to produce sweat. So what will this present as? You know what this is called? This is called Horner syndrome. So this is called Horner's syndrome. Horner syndrome is characterized by, again, what is it whenever you have loss of the dilation? It's constriction. This is called meiosis. What else? You're also going to have loss of some of the ability of the muscles of the palpebra to elevate there. This is going to cause ptosis of the upper eyelid. So this is going to cause ptosis. And you're going to have a little bit of loss of sweating on that side as well. That's called anhidrosis. So they can present with meiosis, ptosis, anhidrosis. This is Horner syndrome, and this is going to be on the left side. Nausea, vomiting, vertigo, unilateral sensory neural deafness, and Horner syndrome. Okay, cool. Let's move on. Now we got this kind of greenish structure here that I want to cover. This is your spinal nucleus and spinal tract that are connected to the trigeminal nerve. Do you guys remember the trigeminal nerve? Here we have what's called the trigeminal ganglia, which sits outside of the kind of central nervous system. And here it has its different divisions. It has the ophthalmic division, V1. It has the maxillary division, V2, and the mandibular division, or V3. And it goes and supplies sensations. Primarily V1, V2 are going to be more of the sensory aspects. V3 is going to have a motor division as well. But they supply most of the sensations on, in this case, let's just say that this is the left side of the face. So they're going to supply proprioception, pain, temperature, vibrations, pressure, all those sensations of the face. Then they're going to send that information inwards to these nuclei, which again, what is this nuclei here in the midbrain for the trigeminal nerve? That's the mesencephalic nucleus. What is this nucleus in the pons? That's your central or principal pontine nucleus of the trigeminal nerve. And the one that we care about here in the medulla is the spinal nucleus, okay, of the trigeminal nerve. Well, what did we damage? The lesion is on the left side, so we're going to damage, this is that spinal tract, right? We're damaging the left spinal tract, and we're damaging the left spinal nucleus. That means that all the pain, temperature, touch, pressure, vibration sensations that are being carried from these divisions on the left side of the face is lost. So you lose sensation, right? There's a loss of what? There's a loss of ipsilateral, loss of sensations on face. Right? And again, that is going to be because of the spinal nucleus and spinal tract being damaged on the left side. Because again, this is taking the sensations from that side of the face. In this case, the left side of the face. Okay, we covered that. So again, so far we've hit the cochlear nuclei that we damaged, right? So this was our cochlear nuclei that we damaged. And then we talked about the sympathetic tract that was damaged. All right. And we talked about the trigeminal nucleus that are damaged, right? So we talked about the trigeminal nuclei that were damaged. And tract. Now let's move on to the next thing. So the next thing that we got to cover here is this next one. So this blue structure here. What is this blue structure that got damaged? We called that the nucleus ambiguus. We're not going to go over all of this in depth. It'll take forever to do it. But what I want you to remember is that the nucleus ambiguus is a part of its fibers that'll exit out here of the medulla. It's carrying what kind of fibers? This is very important. It's carrying special, visceral, efferent fibers. Do you guys remember what special, visceral, efferent fibers supply? Your pharyngeal arches. And this nucleus ambiguus, its axons are actually going to be incorporated from this into a specific 3 cranial nerves. So what happens is The nucleus ambiguus has 3 cranial nerves that its axons are carried on. What are those 3 cranial nerves we have? Cranial nerve 9. That's the glossopharyngeal nerve. We have cranial nerve 10. That's the vagus nerve. And we have a teensy bit of cranial nerve 11, the accessory nerve. These 3 nerves, their axons are carried from the nucleus ambiguus, these special visceral efferent fibers, and they're part of what's called the pharyngeal plexus. And the pharyngeal plexus is going to supply the pharynx. It's going to supply the soft palate and uvula. It's going to supply some of the larynx. And this is very, very important that we understand this, right? So they're supplying the muscles of these areas. So they're supplying the muscles of the soft palate, the salpingopharyngeus, the stylopharyngeus, the palatoglossus, the palatopharyngeus, the tensor veli palatini, all those muscles. They're supplying the muscles of the larynx, right? The intrinsic laryngeal muscles, the cricopharyngeus, the cricothyroid. They're supplying the pharyngeal constrictor muscles, all those things. What is the significance of these? Well, if you remember, the soft palate and uvula, whenever they contract, they elevate and block off the nasopharynx, which is important during the swallowing process, right? So there's going to be ipsilateral weakness of soft palate and uvula. Okay, so that might have some problems whenever they're trying to swallow, right? So basically, whenever they swallow, what does that soft palate and uvula do again? They elevate, they block off the nasopharynx so that food doesn't get regurgitated into the nasal area, the nasopharynx and nasal cavity. So that's one important thing. It also supplies the pharyngeal constrictors. So if the pharyngeal constrictors are damaged, what happens to them? They're not going to be able to contract very well and push food down the pharynx into the esophagus. So there might be some degree of dysphagia, so maybe some oral pharyngeal dysphagia. What else? There's also going to be damage to the actual nerves that are supplying the larynx, right? So because it's supplying the larynx muscles, you know, the larynx has all the intrinsic laryngeal muscles, all the cricoarytenoids, and the cricothyroid, and the cricopharyngeus, all those muscles that are really important for helping with speech and the articulation of speech. Those are going to be damaged. So now the ability to speak is going to be affected. That's dysphonia, and maybe the ability to articulate might also be affected. So there might be some degree of dysarthria. So there might be some dysphonia, and there may be some degree of dysarthria. So again, I want you to remember these big things, that there might be weakness of the actual soft palate on one half. There might be some dysphagia, some dysphonia, and some dysarthria. Let's move on. Okay, the next one that we got here, this is going to be for this kind of maroon structure guy, the spinal lemniscus, right? So we hit the nucleus ambiguus. Now we're going to hit the spinal lemniscus. So now we're going to hit the spinal lemniscus. Spinal lemniscus, what happens here? You guys remember, this picks up pain, temperature, what else? Kind of crude touch and pressure sensations, right? From the body. Goes to a dorsal root ganglion. From here, it goes into the dorsal gray horn, synapses on the dorsal gray horn, right? And crosses over. If it goes into the lateral white column and ascends, that's the lateral spinothalamic tract, right? If it goes into the ventral portion and ascends, that's your ventral spinothalamic tract. And again, there's also that the spinotectal tract. But eventually, the spinotectal, the ventral and lateral spinothalamic tract will fuse together and form the spinal lemniscus. That'll ascend upwards through the medulla, the pons, and the midbrain, and eventually to the thalamus. Well, where's the lesion? The lesion is on the left side, and this portion of the medulla, boom, it's damaged. Follow it back. It's going from the left, crosses over to the right. That's contralateral. So contralateral loss of what type of sensations does the spinal lemniscus carry? There's contralateral loss of pain, temperature, crude touch, and even pressure on the contralateral side of the body, right? So contralateral loss of pain, temperature, crude touch, and pressure sensations. That is important because we've damaged the spinal lemniscus. All right, so now we have here, again, the last part here is our inferior cerebellar peduncles, right? And that's going to be the connection between the medulla and the cerebellum. Middle cerebellar peduncles between the pons and the cerebellum. And then the superior cerebellar peduncles between the midbrain and the cerebellum. What we damaged is this left inferior cerebellar peduncles. The big thing that you guys need to remember is that the inferior cerebellar peduncles is receiving tons of sensory information, right? It's receiving sensory information from your spinocerebellar tracts, like the cuneo-cerebellar tracts. It's receiving it from the dorsal spinocerebellar tract. It's receiving it from like the spinal olivary tracts. There's tons of different tracts that are ascending and putting the sensations going from proprioceptors, going from touch receptors, all these different things that we have unconscious awareness of, taking it to the cerebellum. If you damage the connection between our body's position sense and the cerebellum, it can cause a sense of gait instability or some ataxia. And that is important. So what else can these patients develop if you damage their left, in this case, inferior cerebellar peduncles? You're taking away the connection to the sensations of the body. And this is from that side of the body, right? So ipsilateral ataxia. That's important. And again, that's because of the damage to the inferior cerebellar peduncles. All right, Nijners, so in this video, we talked a lot about the medullary lesions, right? And we talked a little bit about the blood flow. We quickly recapped some of the anatomy of the medulla. I hope this video made sense. I really hope that you guys enjoyed it and learned a lot. If you guys did, smash that like button, comment down in the comment section, and please subscribe. Also, if you guys get a chance, down in the description box, we'll have links to our Facebook, our Instagram, our Patreon, all those things. If you guys want to keep in contact with us, we truly appreciate it. All right, Nijners, as always, until next time.